This is an infected cyst with 10 pops and the skin cancer. Let's get into it. Hey guys, welcome back to the channel. I'm Dr. Jean-Pierre Galliani, a board-certified dermatologist, and today we have an infected cyst on the back with 10 pops and a skin cancer. So our patient presented for an excision of a squamous cell carcinoma on his right thigh. And when he comes in, he says, "Doc, I have this cyst on my back that's been painful, it's been draining. It has actually been drained a week ago by one of the other doctors, but it's still there, it's still draining and painful. So I had to take a look," right? We go ahead and we proceed with the procedure. We drain that cyst, and that's what the video that I have for you today. But I wanted to bring out to your attention this cancer that he had on his leg. This is a squamous cell carcinoma. And squamous cell carcinomas are the second most common cancers in the US, the skin cancers. And the main risk factor is sun exposure, chronic sun damage, right? And they present as red, rough, scaly bumps on the skin that they grow fairly slow. There is a subtype called keratoacanthomas that come up very quickly. They come up as a volcano, super fast. And those are not generally dangerous, right? They come up very fast, but they don't tend to spread roots very often. However, they need to be treated. And the reason why these type of cancers, basal cells and squamous cell carcinomas, tend not to be real dangerous is that we end up finding them very early, right? The advantage of the skin is that we can see it. We can see those bumps growing, and we can take care of them as soon as they become as soon as they become visible. And so the risk of them spreading roots is very slim. However, melanomas are more dangerous because they can spread relatively fast, even as a small lesion, right? So we go ahead and we did the surgery for him, and here is the marking of the ellipse that I made on his leg, and hopefully we'll have a follow-up of his surgical site there for just follow-up for you guys. So let's get into his surgery. So this is the second time here. Dr. Hearn drained it the first time. She got a lot of stuff out the first time?
I imagine, my wife's been getting a lot out in the week since.
Take a deep breath in for me. So I sped up here the numbing procedure just so we don't waste time on it. But again, with inflamed or infected tissues, that acid-base shift causes the skin not to numb up as well. However, there are different theories on that. The number one theory is this acid-base shift, right? So the pH of the skin is closer to 7, so a neutral pH. And infected tissue or inflamed tissue tends to be more acidic because of the lactic acid buildup that's there, and also from nitric oxide reacting to other reactive species or oxygen species, and they create a lot of just an acidic environment. So an acidic environment is where there's a lot of hydrogen floating around, right? And when lidocaine goes into the skin, it has to cross the cell membrane of the nerves to be able to affect its anesthetic effect. And it does that because it's uncharged. So when there's a lot of hydrogens floating around, it reacts with the lidocaine and it makes it charged, and therefore it can penetrate the cell membrane. Now the other theory is that the nitric oxide reacting with these oxygen reactive species form peroxynitrate. It creates peroxynitrate, and this substance, this very reactive substance, will interact with the cell membrane, interacts with the anesthetic, and makes it less effective. So I find that for the most part, I can get patients fairly well numb, even if they're having a lot of inflammation or infection. The key is really to do a ring block. So you're numb all the way around, and I usually use lidocaine that's buffered with bicarbonate. So then our pH is a little bit higher, so more basic. And as we inject in that medicine into the skin, it neutralizes that acidity caused by the infection, and makes our lidocaine work a little bit better. Also, plain lidocaine because it's a more closer to a neutral pH when it's buffered, it hurts a lot less when you inject into the skin. So patients oftentimes come in a lot of pain and you're injecting this medicine and it's not very painful. However, if you have lidocaine with epinephrine, which we oftentimes use, that is a much more painful shot. Okay, so let's keep going. So we have this inflamed ruptured cyst, and it was drained once already. Yep. But it's still accumulating, and you can kind of see that pus, and you can see the cyst particles, still little chunky cyst particles coming in. Yeah, some weird things coming like cyst particles. It's part of the cyst. It's chunky. It's just dead skin that gets built up inside that sac. That's spiny because those cysts are ugly. Yeah. We had one here. Yeah. That the doctor took out, and it was like not particularly attractive. It's really inflamed. It's red and swollen. There's a change in the pH, so there's an acid-base shift here, and sometimes it doesn't numb all the way. So how are you feeling as far as the numbing? No pain? No pain, no. Okay. I haven't been in weight yet. So one thing. Feel the pressure. Yeah, pressure should be okay, but no sharp, okay? The one way that I overcome that is we use plain lidocaine because it's closer to a neutral pH. It works a little bit better, but there's no epinephrine in there. I was worried about it. So you're going to see a lot of these little pops on the skin, right? And that's because of the loculations that get formed inside a ruptured cyst. No, it's far from the actual spine. Yeah, that's what I was worried. Yeah. One of the things that pop number 2 here. One of the things that people ask the most is when something is over the spine, is it close to my spinal cord? There's so much skin and fat between that and your actual spinal cord that it tends to be not an issue. However, if you really have a bad infection, that could be a potential dangerous situation. But for these infected cysts, it's not. That was my drawing. So our patient was commenting, or the patient's wife was commenting on our eyeball there. So as we're breaking the adhesions and these loculations with the curette, I'm able to get to different pockets, and you'll see these small little, drainages that are coming out. One of the most common comment that I get is, oh, why don't you make a bigger cut, a bigger incision to drain it? It's not about making a bigger incision. I'm going to put a diagram here. If you have loculations, like different compartments, different rooms in there, a bigger cut on the top is not going to make any difference. You really have to be able to get to those deeper pockets underneath. And the skin on the back is so thick that we end up with situations like this where he's had a drainage before and it just did not empty out completely. And so there was probably still pockets of that cyst. Well, obviously there were pockets of that cyst left behind, and the body just couldn't heal. It kept causing inflammation, and so it keeps draining and being painful. It's not infected in this situation, it's just inflamed, right? So a bigger cut in the top, to a certain extent, it's not going to make a huge difference. It's really about getting to those loculations, those different pockets, and getting to it. And a lot of that is just patience. You got to press in different directions. You have to use a blunt object to be able to get to those different compartments and loosen up those adhesions to be able to drain it properly. There's no easy way out. Now, a bigger cut is also going to take longer to heal. Could potentially, you can have a lot of bleeding. So there's more complications, in my opinion, right? Some people end up using packing with situations like this. I almost never use packing for these type of cyst or abscess drainages unless there's something very big, and that's because it's not needed, right? So These are fun to do. I did not have my dome for this one because the when I'm pressing on the skin, I tend to feel if it's really under a lot of pressure. And this one wasn't. It was already draining quite a bit. Although some of those pockets can still pop and a lot of things can come out, I didn't feel like there was any areas that were under a lot of pressure. If you like the cyst dome, make sure you comment below, and I'll try to get you more videos on that.
White, cheesy, and then a little bloody from just the blood.
That's better than that stuffy head. Well, so you can do it that way. Well, I won't do it that way.
Well, he's numb, so you know.
So you can see the patient is absolutely having no pain.
This hard.
You know, we're chatting. He's feeling okay. Now, the numbing works only on the pain receptors. It doesn't really work on these proprioceptors that have sensations of pressure, vibration, temperature. So you still feel all of this, all the pressure and everything else. You still feel.
Scissors that we use for
So after I'm done
scissors that we use
with the curette, like I feel like I've loosened up all these adhesions.
The small bishops.
Then I use small pickups, these bishop forceps that are very small, but they have nice teeth to grab onto the wall of the cyst. Because oftentimes when these cysts are on the back, especially in the back, the wall of the cyst ends up just breaking down and almost becoming super attached to the wall, to the surrounding skin,
forceps and
like
small
wallpaper.
scissors to see
it's
if
just
we can
stuck
get
there
the
like
sac.
wallpaper. And even the curette cannot break it down. It's almost like glued to cement. And you need those forceps to grab that skin and sometimes cut them to loosen up those pieces of wall.
The sac out. But yeah, but the problem is that because it ruptured underneath your skin, sometimes it's hard to get it all out. So we need to get it to heal without getting inflamed.
So oftentimes, I tell patients, because it's inflamed and infected, oftentimes you still need a surgery at some point, because as that wall gets reformed,
so I can see wall material.
As the wall gets reformed, then we have to do a surgery. But sometimes we don't. Sometimes I get it all out. So you can see here.
So you see this little white thing right here? That's part of the cyst wall. So that looks like skin, but it's underneath
even
your
that little
skin,
piece of,
and that's why it builds
wall
up.
Could regrow and become another cyst.
So chunks of it, yeah.
And this is the cyst that keeps on giving. 9 pops, 9 little releases, and quite a lot of stuff in there. I mean, you'd be surprised how big these cysts get on the back. They keep going and going and going.
So you missed all the stuff that came out.
And this is after one drainage by a doctor, and the wife was also draining it at home. Just a lot of material.
So some of the skin was coming out.
Sort of, but you don't go tough.
You can turn just a little bit for me right there. Actually, right there is good.
You have that big. I don't know how much different that would be.
So our 10 pop is a mini pop. Just the very last bit in there. So at the end of this video, I'm going to have the post-op, or like a week out, and he's healed quite well. Hopefully this doesn't grow back. I told him that if he feels a bump back there, we'll schedule him for surgery. I don't schedule people right off the bat for surgery because sometimes it doesn't grow back. But they need to be able to communicate to me if they do feel something before it becomes painful. That's the key. Before it becomes painful and draining again, if they ever feel a bump back there, we schedule for a surgery and then we can cut out whatever is there.
That was a deep cyst, man. Yeah, it's huge. So how are you feeling? Any pain here? You're good.
As that cyst grows up,
So
that skin starts thinning out on top.
Thin. I can feel the probe.
Yeah, so I remember it was just like a divot in there.
Extended all the way over there. Again, I'm kind of crazy.
How many inches?
Well, it's about 1 or 2 inches.
I told him to get that out.
Cysts get formed when you have a clogged follicle. from just dead skin, oils, dirt, sometimes trauma. If you have injuries, that drives the skin, the top layer of your skin, deeper into the layers here, and that then leads to a cyst. People that have acne have a higher risk of having cysts.
If you want to know how a cyst gets formed, I made a short on it, so go through my channel and find it. I'll try to put a link on it below.
You say you smoke?
That's key. Smoking can clog up your pores, cause more acne. Smoking is bad, people. So here, you know, I do flush oftentimes with a little bit of saline inside just to loosen up any particles of the cyst, just to make sure that everything is out and have it heal without any inflammation or infection. So he did not require any antibiotic. That's like 3 days after, and this is 7 days after. A little redness, but it's fully closed and no bumps. So that's the video, 10 pops in the skin cancer. If you like this content, make sure you subscribe, drop me a comment. Let me know what kind of videos you want me to make, all right? I'll see you in the next video.